Welcome to the deep dive. Today, we're plunging into a topic that, well, it touches every single one of us and often leaves us scratching our heads. Healthcare costs. We all see those national budgets, right? The headlines about rising expenses, the seemingly endless bills driven by everything from cutting-edge tech to, an aging population and chronic diseases. It's a huge challenge, and it really begs a central question for you and me. Given how much we collectively spend, are we actually getting proportionally healthier? Where's the real value for our investment in health? Now, historically, our understanding of value often came from these highly controlled clinical trials, which are great for clean data, sure, but they often paint a picture that's, well, quite different from the messy, complex, unpredictable landscape of the real world. They often miss the true costs, the downstream impacts like unexpected ER visits months later or the real hit to patient productivity. And crucially, they might not capture the true benefits when a treatment is applied to diverse real-world patient populations. So how do we get a more accurate, more holistic view? Well, our sources highlight that the discipline dedicated to quantifying value in health is health economics. And here's where it gets really interesting. It's being revolutionized by an indispensable new tool, real-world data, or RWD. This isn't just theory anymore. RWD moves us beyond models to see what's actually happening in routine clinical practice, providing, well, unprecedented clarity. Our mission for this deep dive is to understand how this flood of real-world information can help us spend healthcare dollars more wisely and maximize health outcomes for everyone. It's truly the central economic question of modern healthcare, and we're tackling it today. What makes this journey so crucial right now?
Well, what's fascinating here is that this isn't just some abstract discussion about numbers and spreadsheets. Understanding these concepts is absolutely crucial for anyone trying to navigate the complexities of modern healthcare. I mean, whether you're preparing for a big meeting, trying to catch up on this rapidly evolving field, or maybe you're just immensely curious about how these massive multi-billion-dollar decisions actually get made. Real-world data has this incredible, almost X-ray-like power. It can reveal both the comprehensive, often hidden costs and the true real-world effectiveness of treatments and interventions. It really gives us a far truer picture of value than we've ever had before. And that picture directly impacts your health and, frankly, your wallet.
That's a vital point, the direct impact. And before we dive headfirst into RWD, maybe we should clarify what health economics actually is, because there's this common misconception, isn't there, that it's purely about cost cutting, just, pinching pennies. But from what our sources suggest, that's really not the full story, is it?
Not at all. No, health economics is far broader than that. It's essentially the study of how we allocate our scarce resources, things like money, time, personnel, technology, to produce the maximum possible health and well-being for an entire population. Think of it as the science of value and choice in health. And to quantify that value, health economists use several key evaluation concepts.
Okay, so if it's about getting the most health for our resources, what are these analytical tools? How do they help us actually measure this idea of value?
Right, great question. So one of the primary tools, really a workhorse in the field, is cost effectiveness analysis, or CEA. Now, this isn't about finding the cheapest option necessarily. It's about getting the best bang for your buck. CEA compares the costs of different health interventions relative to the health benefits they deliver. And here's where it gets quite specific. Health benefits are often measured in natural units like life years gained, or even more powerfully in something called quality-adjusted life years, QLYs.
QLOIs. Okay, that sounds like a bit of a mouthful. How does that translate into something we can, really grasp?
It's actually simpler than it sounds. Basically, 1 year lived in perfect health is considered 1 QELI. But let's say someone lives a year with a significant disability or severe pain. Well, that year might only be valued as, say, half a QA. So CEA helps us ask questions like, what is the cost per QELI gained for this new treatment compared to the existing standard? It lets us compare vastly different interventions, a drug, a surgery, a public health campaign, on a more level playing field.
Okay, that makes sense. Comparing value using a standard unit.
Exactly. Then we have cost-benefit analysis, or CBA. This takes things a step further. This approach tries to value both the costs and the health benefits in monetary terms. So imagine a new childhood vaccination program. Let's say it costs society $100 million to implement. But if it prevents illnesses that would have resulted in $200 million in future hospital costs and also saves $50 million in lost wages because parents don't miss work caring for sick kids, well, then the total monetary benefit is $250 million. Since that benefit clearly outweighs the $100 million cost, CBA shows this as a highly worthwhile societal investment. It frames health outcomes in economic terms that policymakers often find very compelling.
Right, translating it all into dollars and cents. Okay, so CEA looks at bang for buck in health units, QALYs, and CDA uses money. What about when a specific health system or an insurer is trying to make a decision just for their budget, like right now?
That's where budget impact analysis, or BIA, comes in. This is a very pragmatic tool. It's used by specific payers, a hospital, an insurance plan, a national health system. BIA answers the question. Okay, if we adopt this new, potentially expensive intervention, what are the total financial consequences for our specific budget over the next, say, 1 to 5 years? Because, you see, a new drug might be incredibly cost-effective in the long run, offering great QALYs for the money, but a BIA asks, can we actually afford the upfront costs right now? It's all about that immediate financial feasibility.
Got it. The immediate hit to the wallet.
Precisely. And kind of tying all these concepts together, we have this bigger shift towards value-based healthcare. This is the overarching paradigm shift that's really transforming how care is delivered and paid for. Instead of the old model, paying providers based on the volume of services, fee-for-service value-based models, tie payments to the value created. And that value is explicitly defined. Health outcomes achieved relative to the cost. This fundamentally changes the incentive structure. It rewards high-quality, efficient care, not just doing more stuff.
So these are the specific analytical frameworks, cost effectiveness, cost benefit, budget impact, that really empower this whole idea of value-based healthcare. But here's the kicker you mentioned earlier. Historically, all these evaluations often had to rely on data from those idealized clinical trials, which you said are clean but maybe detached from real-world complexities. And that, I gather, is exactly where real-world data steps in to fundamentally change the game.
Precisely, yes. That's the profound challenge RWD helps us tackle. It fundamentally shifts our analytical capabilities. Before RWD became more accessible, we were often making these huge decisions with, well, maybe one hand tied behind our backs. Now we can populate these economic models with information that reflects what's actually happening out there in everyday clinical practice. It moves our analyses from the sort of sterile lab environment right into the messy, complex real world.
So if I'm understanding correctly, RWD basically injects real-life complexity into what used to be more theoretical models. It takes us out of the lab and puts us squarely in the clinic. How drastically does this change our ability to capture the comprehensive costs of care?
Oh, it's a seismic shift. It really is. Traditional clinical trials, while excellent for proving if something works under ideal conditions, they're notoriously poor at capturing the full economic impact of a disease or treatment. They typically only track costs directly related to the trial itself. RWD, on the other hand, it gives us this panoramic view of costs. For direct medical costs, think about these vast administrative claims databases, the integrated electronic health records. They are absolute treasure troves of information. We're talking millions and millions of patients. We can literally see almost every single billable event, every hospitalization, ER visit, outpatient consultation, filled prescription, lab test. This allows us to calculate the true total cost of care for a patient with a specific condition, accounting for everything that happens, not just what's strictly protocol in a trial.
Okay, a much wider lens. But the economic burden goes beyond just those medical bills, right? What about things like people being unable to work or the impact on families and caregivers?
Absolutely. You've hit on a critical point. The economic burden of illness extends far beyond direct medical bills into what we call indirect costs. Things like less productivity from being unable to work, or the immense, often hidden costs associated with caregiver burden. These are substantial. Sometimes they amount to as much as or even more than the direct medical costs. And while historically they were much harder to capture, RWD is making this more feasible now. By carefully linking de-identified health data with other data sets, think disability claims or maybe employment records, researchers can start to quantify these significant indirect costs. This gives us a much more complete picture of the total societal cost of a disease, not just what the insurers are paying out.
Right, the societal cost. But cost is only half the equation for value, isn't it? What about the other side, the outcomes? Does it actually work in the real world?
Exactly. Cost is only half of it. An intervention isn't truly valuable if it doesn't work effectively in the real world for real people. RWD allows us to measure the true effectiveness of interventions in diverse, heterogeneous patient populations, and under the actual, sometimes messy, conditions of routine clinical practice. So, for instance, a clinical trial might show a drug works wonders when taken perfectly by a carefully selected group of patients. But RWD might then reveal that, in the real world, maybe half the patients stop taking it after 6 months. Why? side effects, maybe they can't afford the copay, access issues, whatever the reason, this dramatically changes its real-world effectiveness and its overall value proposition.
Ah, so RWD reveals not just if something works in theory, but how well it actually performs out there in the wild, so to speak, for all kinds of patients with all their other health issues complicating things.
Precisely. And RWD is also essential for measuring long-term outcomes, things that trials often don't follow for long enough. And the impact of comorbidities those other health conditions people have. These are often excluded from trials, but are critical drivers of real-world costs and benefits. And crucially, the inclusion of patient-reported outcomes, or PROs, within RWD systems allows us to directly measure the impact on quality of life. That's the Q and QA we talked about. This leads to far more meaningful cost-effectiveness analyses that truly reflect what matters to patients. Living longer, yes, but also living better.
Living better, right?
And this brings us to another really powerful application: identifying efficiencies and inefficiencies. As a health economist using RWD, you almost become like a medical detective, sniffing out waste within the healthcare system. And trust me, sometimes what you uncover is, well, it's jaw-dropping. We're talking about situations where it almost looks like two completely different healthcare systems operating in the same city, serving similar people but with wildly different price tags and results. By analyzing large RWD sets, we can identify why one hospital might have a 30% higher cost for the exact same procedure, with the same or even worse outcomes compared to another hospital just across town. RWD makes these profound variations visible, and this visibility helps us identify and promote best practices, reduce unnecessary procedures, and pinpoint areas of what we call low-value care interventions that drive up costs significantly without delivering commensurate health benefits. In a system with finite resources, eliminating that kind of waste is absolutely crucial. And RWD is probably our best tool for systematically identifying it. But this raises an important question.
Yeah, how are these insights actually used? How do they translate into real-world decisions?
That's the key, isn't it?
Right, because these aren't just fascinating academic findings floating around. Our sources are showing they're actively guiding multi-billion-dollar decisions across the entire healthcare landscape. So let's talk about where this data makes the biggest real-world splash.
Absolutely. Okay. One key area is informing formulary decisions. So health insurers, hospital systems, pharmacy benefit managers, PBMs, they all maintain these lists of approved covered drugs. That's the formulary. When a new drug comes to market, often with a hefty price tag, these organizations now increasingly use RWD. And crucially, RWD from their own patient populations. They conduct cost-effectiveness and budget impact analyses using this data. They compare the new drug to existing alternative based on how they actually perform in their specific members, not just in some distant, idealized trial population. This real-world evidence, or RWE, helps them decide, should we add this drug? At what tier? Under what conditions? It ensures their decisions are based on the best available evidence of real-world value for their people. It's about smart buying, really, for millions.
Smart buying based on their own data makes sense. What about bigger picture things like government policy?
Yeah, beyond that, RWD is essential for guiding policy and resource allocation. Think governments, public health agencies. It helps them make smart, evidence-based decisions about how to allocate public funds, which are always limited. For instance, a government can use RWD to model the long-term return on investment for, say, a new national vaccination program, or maybe a tax on sugary beverages, or a community-based diabetes prevention initiative. They can use RWE to see how these policies are likely to affect future hospitalization rates, the prevalence of chronic diseases, overall healthcare spending down the line. This helps justify investments in prevention that might seem costly upfront, but pay off big time in the long run.
Proving the long-term value of prevention. Okay. And what about the companies making the drugs and devices themselves?
Ah, yes. RWD is absolutely crucial for demonstrating value for industry. Pharmaceutical companies, medical device companies, they are major users of this data. Because look, in today's value-focused environment, it's just not enough anymore to show that your product is safe and effective in a clinical trial. That's table stakes. Companies must now use RWD to demonstrate the real-world value of their products to the people who pay for them, the payers and providers. For example, a new drug might have a high upfront price, but RWD can potentially show that it significantly reduces costly hospitalizations down the road, or prevents severe complications, or maybe helps patients return to work faster. That proves it's actually a highly cost-effective and valuable intervention in the long run, despite the initial cost. RWD has really become the universal language of value that payers understand.
And it sounds incredibly powerful, transformative even. But, with such immense power comes immense complexity, right? RWD feels like a huge step forward, but surely it's not a magic bullet. I imagine there's a need for, well, immense methodological rigor when dealing with these vast, sometimes messy data sets.
That's a critical observation.
Yeah.
Absolutely. Using RWD for these high-stakes economic evaluations requires navigating some pretty significant challenges. First off, there's just the basic issue of data quality and completeness. RWD can be messy. It's collected for routine care, not research primarily. So we might encounter missing cost data, inaccurate diagnostic codes, or incomplete information on patient outcomes. Any of these, if not handled meticulously, can seriously skew the results of an economic analysis.
Okay, so the data itself can be imperfect. What else?
Well, perhaps the most critical challenge, the one that keeps health economists and epidemiologists up at night, is distinguishing causality from mere correlation. This is the issue of confounding. As we've likely discussed before on the show, just because we observe in RWD that patients taking treatment A seem to have lower healthcare costs than patients taking treatment B, it doesn't automatically mean treatment A caused those lower costs. It could simply be that doctors were, perhaps subconsciously, prescribing treatment A to healthier, less complex patients to begin with. That's a classic example of confounding by indication. The groups weren't truly comparable from the start.
Right. The correlation is not causation problem writ large. So how on earth do you untangle that? How do you try to isolate the effect of the treatment itself from all those other influencing factors swirling around in the real world?
It's tough, but that's where sophisticated statistical methods come in. Think of it like this. RWD allows us to identify patients who, at the outset, before treatment starts, seem almost identical in every relevant way we can measure: same age, similar health history, other conditions, maybe socioeconomic factors. The only key difference is the specific treatment they received. These advanced methods, things like propensity score matching or instrumental variable analysis, essentially help us match these similar patients up across treatment groups. It creates comparison groups that are as close as possible to what you'd get in a randomized trial, but using observational, real-world data. It's like carefully sifting through a giant pile of sand to find pairs of almost identical grains so you can then compare their subsequent journeys fairly. It's incredibly complex work, but absolutely vital for drawing valid conclusions about cause and effect. Wow. Okay, so it's like simulating a trial after the fact using statistics.
Yeah.
That sounds intense.
Hmm.
What other hurdles are there?
Well, then there are the technical challenges of interoperability and linkage. The true power of RWD often comes from combining different data sets. For instance, linking clinical details from electronic health records with cost data from insurance claims, and maybe quality of life data from patient surveys or registries. The technical hurdles, and importantly the privacy-related challenges of doing this accurately, securely, and ethically, are substantial. You have to connect the dots without compromising confidentiality. And this brings us squarely to privacy and governance. Using sensitive financial and health data requires an absolutely unwavering commitment to patient privacy, robust data security measures, and transparent governance frameworks. We need these to build and maintain public trust. Without trust, the whole enterprise falls apart. And lastly, related to trust is the need for transparency of methods. These economic models built on RWD can be very complex. It's crucial that the methods, the assumptions made, the data sources used, all of it, are fully transparent. Decision makers need to be able to critically evaluate the analysis and understand how the conclusions were reached before they can truly trust and act on the findings. It's about showing your work.
That transparency definitely sounds key to building trust in these powerful new tools. And it feels like a perfect segue to looking ahead, maybe painting a vision for the future of healthcare. It really seems like RWD is becoming the indispensable fuel for this global shift we're seeing towards value-based care.
That's precisely right. I think that's the perfect way to put it. The entire premise of value-based care, paying for patient outcomes, for quality, rather than just the sheer volume of services provided, that whole idea is fundamentally dependent on our ability to accurately and comprehensively measure those real-world outcomes and their associated costs. And RWD is, frankly, the only way we can do this reliably at scale across diverse populations and complex pathways of care. It's the bedrock measurement tool. So yes, I absolutely envision a future where all significant healthcare investment decisions, everything from a national policy on preventative care right down to a single hospital's choice of a new medical device, are consistently informed by robust, timely, real-world evidence derived from RWD. And the outcome of that, it should lead to healthcare systems that are not only more clinically effective, but also more sustainable financially, more equitable in how they deliver care across different groups, and ultimately more accountable to the patients and the communities they serve. And, artificial intelligence will almost certainly play a crucial role in this future.
AI can help us process these vast, complex troves of economic and clinical RWD, identify subtle patterns of high-value and low-value care that humans might miss, and potentially generate insights in near real time to guide better decision-making at the point of care or policy level.
It's quite a vision. The journey of real-world data into the heart of health economics really represents a profound shift, doesn't it? Moving this discipline from something often based on theoretical models and, let's face it, sometimes idealized data, to a truly applied science, grounded firmly in the real-world quantification of cost, impact, and genuine value. Answering this monumental challenge, how to manage burgeoning healthcare costs while actually improving health, is one of the defining missions of our time. And RWD, when it's used with rigor and responsibility, certainly seems like our most powerful tool for finding those answers. It allows us to see, as one source put it, what works for who and at what cost, not in a controlled laboratory, but in the complex reality of our communities.
And this isn't just some fascinating abstract topic for economists. It has direct implications for your health and the future of the healthcare you experience every single day.
Indeed. And maybe a final thought to leave you with. We talked a lot about how RWD empowers health systems, policymakers, industry. But think about this. In a world increasingly driven by data, how can you, as a patient, as a citizen, perhaps as a healthcare professional yourself, how can you demand more transparency? How can you push for more evidence-based decisions about how our precious healthcare resources are allocated? How can we all advocate for the responsible, ethical use of RWD to build a healthcare system that truly delivers the maximum possible value and quality for everyone? It's something to mull over, perhaps, now that you have a deeper understanding of this relentless search for value that underpins so many of the healthcare choices being made all around us.